Welcome, everyone. We'll wait just a couple minutes or seconds here to let everyone join, and then we'll begin. Okay, welcome to the Healthcare Lounge. Our session today is titled Easily Reduce Surgeries, Hospitalizations, and ER Visits by Managing Employee Health, with guest speakers Michael Hennessey of Diathrive and Heidi Ojha of Aware Health. Now I will turn it over to Nelson.
Thank you, Kendall. Welcome to the Healthcare Lounge. It's a pleasure to be back with you this month, and I am extremely excited about the topic we have today because I think we're actually going to host, let's see, not hoe, I guess that's manual. We're going to plow some new ground here. It's a little more global, I guess. Uh, because we talk about in next gen healthcare, next gen health plans, we talk a lot about reducing the cost of the care that's provided. Now, we also talk using second opinions and other techniques of avoiding claims that are unnecessary. But I think we don't expand that definition of unnecessary care far enough. And that's what we're going to be talking about today with my guests. And it's a pleasure to have you both here. Heidi and Mike are doing great work. And some of you will know Mike from Ascend conferences where he and Diathrive have been a feature. And for those of you in our Next Gen Benefits Mastermind group, of course, Mike has been with us for a number of our mastermind summits over the last couple of years. But welcome to the Healthcare Lounge, both of you, Mike and Heidi. So I want to frame this up just a little bit before we get rid of the visuals and just bring everybody up on screen. At the heart of what next gen advisors do is risk management. The biggest risk is the employer is paying for employees' health care. What is the risk, both primarily the financial risk around that obligation, and how do you mitigate and offload and control that risk? Well, unfortunately, most of the work that we do is done through the rearview mirror, looking through the rearview mirror. What were the claims last year? What were the high utilizers? What were the conditions that drove the healthcare? What were the drugs that drove the healthcare spend? And yet, risk management should be forward-looking, proactive, not reactive. And certainly, there are some excellent data analytics programs on the market that do look at trends and attempt to predict, therefore predictive analytics, what's coming down the pike. But there are other ways to do that besides just the data analytics. And the most effective is population health management. And by that, I don't mean wellness. I'm talking about health risk assessments, actual blood draws in order to do an extensive panel on each employee so that the employer, who is on the hook for 80% or so of the healthcare spend, is able to evaluate and recognize, identify, and prepare for risks that are coming down the pike. And two areas that we're going to talk about today that both have tremendous cost attached to them. And in the case of diabetes, potential long-term expenses and massive expenses as you get into comorbidities, you get into blindness, you get into amputation, limb amputations, et cetera. Diabetes is an extremely devious and destructive disease. The other we're going to talk about, MSK, musculoskeletal. it can also be extremely costly, not just in terms of the cost of treatment, particularly surgery, but also in time, downtime, lost productivity, et cetera. So both of these two conditions, MSK and diabetes, are two areas where we don't have to just look backwards. We can look forward. And in many, many cases, the risk is extremely predictable. And as you're going to hear, extremely manageable, surprisingly manageable. So I want to take a look real quick at the frequency and severity of MSK surgeries. And you see on one side of the screen a list of regions of the body where MSK problems occur. The two I want to point out because they are the highest severity, and severity, of course, being cost, frequency being the number of these procedures. Hip surgeries, over $200,000. Knee surgeries, over $100,000. And these are not uncommon. Now, currently, our strategy is when that happens, we're going to mitigate the cost. We're going to use wisely used bundle surgeries. We're going to use ambulatory surgery centers, certainly not uh, hospital ORs, but we tend to address the problem from a cost standpoint and not a preventative standpoint or a non-surgical standpoint. Now, there is an increase, and I'm a huge fan of non-invasive treatments, primarily regenerative medicine. I think there's a tremendous opportunity there, but you're going to hear from Heidi that there are ways without even going that route to address MSK problems. The other numbers I wanted to share with you is the higher utilization of emergency rooms and hospitalizations by patients with diabetes. These are eye-popping numbers because, as we know, there's a substantial cost attached to both the hospitalizations and ER visits. So if we can evacuate those, if we can eliminate those ER visits, excessive ER visits, those excessive hospitalizations, we can reduce that number dramatically. There's going to be a substantial savings on the part of the plan, but a substantial savings, I don't mean financial, I mean otherwise, for the patients, for the diabetic patients, because if they're not needing the ER, if they're not needing hospitalization, their lives are a lot better because their health is a lot better. And we're going to talk about how we can manage diabetes. Now, before I bring Mike and Heidi into the healthcare lounge writ large, I want to mention just a little housekeeping. As we're talking, you're going to have questions pop up. Please don't wait to the end to bring the question up. Go ahead and enter it in the Q&A box. And if do it when you have the question, you're liable to forget it. I always do. Forget my good question at the end Q&A, and I can't remember the question. And we'll do everything we can to get to your questions before the end. All right, it's time to bring Mike and Heidi into the Healthcare Lounge. Welcome to you both. Great to have you. Heidi, you're in the Bay Area today?
Yes, I am.
And Mike is in the great state of Utah in the Salt Lake City area, which, as we've discussed, we'll be visiting you in July for the 10th annual Ascend Conference. Really excited about coming to Salt Lake City. But let's talk about the problem around, and Heidi, I'm going to start with you ladies first. Let's talk about the problem, frame it up just a little bit more around the way we deal with MSK problems today. What do you see in the workplace and in health plans around those MSK issues?
I think the biggest issue is honestly, like if I were a plan advisor and my goal was to control cost, like we have to have clarity around the problem. Otherwise, we can't come up with the right solution for the problem. And what I see oftentimes is MSK goes completely under the radar because it's never going to be the top cost claim. cancer infusions, open heart surgery, all of that's going to show up as number one if you stack rank every single claim. But if you look at categories, MSK, based on our experience, is always number one. It's maybe number two in some cases, maybe three, but it's really of the top three every single time. And so the reason for that is half the population has an MSK problem. Half the members on your medical plan have this issue, whether it be a headache or knee pain. Just think about it. It's so common, right? So if you add up all the claims, and a certain number of those will go in for surgeries that are very expensive, then even though it's medium size in terms of ranking by individual line item for claims, it's going to almost always be one of the top problems an advisor is trying to solve for.
What are some assumptions we make about MSK, Heidi, that you think are incorrect, that are costing the plan and costing the employee, the patient, both financially and otherwise?
I think the biggest assumption is you need imaging to diagnose it. That's a huge assumption.
Nelson,
Okay, so
can I add on to that just briefly? Because I
yes, of
know a
course.
little bit about Heidi's solution. And I think one of the things that strikes me whenever Heidi and I have talked to clients together. And Heidi, don't you think also it's that we assume, I think there is an assumption on behalf of a lot of us in the industry that the data that we have is the right data to be making decisions off of. And, the healthcare system is set up with certain pathways. There's a big assumption that those pathways are correct. What about asking, but what percentage of the claims that you have could be avoided using Aware Health? That's a data point that, on their own, people don't get generated by claims data, right?
Yeah, I think that's a good point. It starts with an image that's inappropriate ordered, and then that triples their risk in some cases for going surgical route. So, we should be questioning, do you need an image to diagnose? Do you need surgery to treat? And so those are very important questions. And the best, discount on a claim is when you can avoid altogether. So I just want to make myself clear that if you look at all MSK, about 20% are going to be traumatic. You do need imaging to diagnose a fractured hip. The 80% of MSK, if we kind of include autoimmune in there, is more wear and tear. And those are the conditions I'm talking about that do not need imaging for the most part to make a diagnosis. So even an X-ray is dangerous because you see the bone of bone, you assume that's the cause of your problem, off you go to a knee replacement.
So Heidi, share a little bit of your background with your doctorate in physical therapy and how that has brought you to where you are today with Aware Health.
Yeah, so I'm a doctor of physical therapy by profession, and I treated patients for about 15 years, taught as a professor for 9 years, and now running this business because this is a huge problem. If you look at the data, most of these surgeries, shoulder, knee repairs, back fusions, joint replacements, if you look at the data, compared to doing nothing at all, they're no more effective on average. There's going to be the edge cases that are, but on average, looking at large systematic reviews, that's a problem. How many of them are being done right now? And it starts with diagnosing their pain correctly from the beginning, and imaging throws that diagnosis off course.
Right. So if you're hearing what I'm hearing as Heidi's talking, this is eye-opening. This is when we first spoke, when Heidi and I first spoke, I was a bit slack-jawed over this because her approach and the data she brings is unique. We've not seen this before. We've not looked at it this way before. And I think part of it is the discipline out of which you bring this data and you view this data, Heidi. There's a different presumption in your world than there is, let's say, in the surgical world. And the imaging world. I mean, that's great. People who do imaging and radiologists do that, and that's an understandable, confirmation bias, I guess, that might exist. But looking at the data, in my background, I actually come out of public policy. I don't know, Heidi, if we ever spoke about that. I used to run think tanks, and everything we did was data-based. It's like, well, you want more money for this government program. That's fantastic. Been running for 3 years. You're supposed to be reducing poverty among this cohort of the population. How you doing? Let's see the data. And if the data supports what you're doing and you're lowering the cost of poverty and or lowering the percentage of poverty, and it's a good cost analysis, cost benefit analysis, let's keep doing it. Otherwise, let's do something else. And so I'm a big believer in data-driven decisions. So when you raise this topic, Heidi, it's extremely provocative, because it says that we're spending way too much on care that isn't necessary for the patient. Can you speak just a little bit, and then I want to get to Mike and talk about diabetes, but can you speak a little bit to the inefficacy, the lack of results? How is that measured? How can you say that all these surgeries are no more effective than doing nothing?
I don't know why that is. I just know when we look at research, and there's a study by Harris and colleagues that looked at any randomized control trial comparing surgery to no surgery. So it's very complicated to do a study like that. You have to convince the patient they've had surgery, and they even make an incision in your skin. So I'm sure they were paid really well to do these studies, but they didn't know if they had surgery or not. And when you look at the outcomes, there's no difference. I think most of this research happens in countries with socialized medicine, not the US, because the results are fairly threatening to the profession here. Surgery and also hospitals make a lot of money getting reimbursed for these procedures. So there's no incentive for our system to change right now. So that's why I worked for about 20 years, including, all the years I taught in academia. I got grant funding. I was really motivated to do a lot of these studies and look at working with employers directly, getting ahead of the claims cost, because working in the traditional system, there's no incentive to do that. So that's what brought me to Aware Health.
All right, so I want to come back to what Aware does and how your alternative works in lieu of the status quo approach. But Mike, I want to bring you in. Let's talk about diabetes, and let's talk about the problem. What happens today with diabetic patients, and why does that lead to so much utilization, so much higher utilization of the emergency room and the hospital?
Yeah, well, there are a lot of things. I mean, structurally, from a health system perspective, there's of course almost no money in no reimbursement really. Kind of as a segue from what Heidi was talking about, I think that one of the big reasons for Heidi's for Aware Health success is that surgeons get paid a cut and they don't get paid to not cut. My dad was a surgeon, so just that there are incentives involved that inevitably skew results. And I think some of the MSK issues that we're talking about, and diabetes is the same way. I mean, a health system gets paid 1,000 times more for a heart attack than they do for preventing it. In fact, there's how often do you even hear about that? Not very much. And diabetes, of course, is a main contributor to cardiovascular issues. So there's that there just really isn't a lot of prevention out there. And then the other thing that I think universally people with diabetes encounter, regardless of the severity of it, is there's just a lot of barriers out there. We've, since the Affordable Care Act, over 10 years ago now, people have financial barriers, administrative barriers. We hear from people on a weekly basis that, they can't test their blood sugar as many times as they want to. They haven't been managing their diabetes at all because of the size of their deductible. To get to a clinician like the ones that we have as part of our solution, somebody might need to make 3 appointments, wait in waiting rooms 3 times, pay 3 copays just to get to talk to somebody. So there's a real burden in terms of just the barriers that exist, and then there's kind of some psychosocial barriers as well, just in terms of the way that diabetes is talked about generally by healthcare professionals that disincentivize and demotivate people from really engaging in managing it. So those are a few of the issues with them, and because they don't manage it, of course, that's why, if you're going to make somebody pay out of pocket for the first $5,000, which is a very common deductible nowadays, was just looking at a group a couple of days ago, that's the deductible. Well, if they have to come out of pocket for $5,000, but their emergency room deductible is only $500, they're actually incentivized to just ignore the day-to-day management of it and not pay for it, and then go to the emergency room when they have an event, right? I mean, they just saved 90% or whatever that math is, but by not managing it. So that's why you have some of the numbers that you showed as far as the increased utilization and hospitalizations, increased utilization of the emergency room, and a higher percentage of hospitalizations for people with diabetes, because really the way the healthcare system is designed, it's really not, there are not incentives in place for either the providers or the consumers of healthcare to manage it.
So, compliance, patient compliance with the treatment regimen for diabetes really is the problem. They're not managing, they're not taking their medications, they're not tracking their blood sugar, et cetera. Am I hearing that right?
Yeah, that's right. Yeah, and the high cost, and they're not doing that because of barriers that exist that are actually just they're just rational decision makers, just like all of us. And so and the way that the healthcare system is structured, most health plans are structured, they don't get the management and the ongoing support too that they need. Even the way that they're viewed and talked about by medical professionals is an issue. When people talk, you use the word compliance, which is a very common term. We don't use that word because I don't go into the dentist and get told that I'm a non-compliant flosser. If you're trying to get me to floss my teeth, there's there's a lot of facets to it, but basically the lack of just a clear, easy, simple, efficient way of managing it, I think is the number one problem with just all the barriers that exist for people doing that is really the issue.
I would think too, though, managing anything is a challenge. It's the habits that you have to get into, whether it's dietary, whether it is compliance, taking your medication regularly, checking your blood regularly. People have a hard time with regular. And so I'm guessing too that even if the financial barriers aren't there, that a lot of people just find it easier to eat like they always ate, not check their blood sugar, and then voila, there's an episode where they're being rushed to the emergency room or being put in hospital. So does that make sense? Does that sound right?
Yeah, I think that and definitely there are a lot of reasons for that. I think one of the other ones is just the understanding of why these things are important. If you only have, the average waiting time to even get in to see an endocrinologist in this country is 90 days. So if you see a primary care and they refer you to an endocrinologist, and then the endocrinologist would need you to refer you to an educator, that can be a months and months long process, just having somebody wait that long. right, is a reason why they might not have their questions answered, might not understand. I can tell you that tons of people that are testing their blood sugar today don't actually know what the numbers mean. The number one question that members of ours who have diabetes have is just, how am I doing? You know, is 200 good or a bad number? And they don't get that out of the traditional healthcare system because, again, you know, it's a fee for service model and people are cycling in and out of the office really quickly. And there really isn't in medical school, you know, you don't take any communications classes. You don't get some of the public speaking communication classes that you're an expert at. So you know that there isn't any the clinicians, and the clinicians are not paid based on whether or not the people have learned the importance of doing these things in their office. They're just paid for having seen the person. So again, there's financial and structural issues that really don't set our system isn't set up to actually really educate people and get it. And if you talk to clinicians all over the country who, for example, run accredited diabetes education programs, to a person, they will almost always blame the people for the bad results of their programs. Oh, we teach the right things, but these people just won't do it. But, you know, in education, you know, when you have kids in school, you know, you get mad at the teacher if you know, if the person goes to class, if your child goes to class, does their homework, and, you know, still can't seem to learn the things, and you go and get more help, and you know, go to TA hours and things like that, right? And our healthcare system doesn't do that. It just you just keep cycling through the system, and nobody ever cares whether or not you understand the reasons why you should manage it on a regular basis. And once people start getting talked to appropriately and start grasping it, the odds of them doing that go up just because they understand the why.
I've had dozens of primary care physicians tell me over the years they get 5 to 7 minutes, at most 10 to 12, to go in, see the patient, hear what's wrong. There is something wrong. They're there for a reason. They don't feel good, and examine them enough to at least, I guess, validate the complaint. But they said all we have time for is to either, one, write a prescription, or two, write a referral to a specialist. That's it. So there's no education going on there. And so now you're off to the endocrinologist in the case of a diabetic. So it's no surprise that there's a lack of understanding, lack of education. Heidi, let's talk about the alternative to the status quo that you are recommending based on the data that you've seen and the work that you've done with patients.
Yeah, so maybe I could just frame it in a couple examples and highlight some of what Mike was talking about, because a lot of it directly applies to the orthopedic silo. So let's just take an example where somebody has a stiff knee. Typically, they'll go into a primary care office, and of course, primary care, you know, the more they prescribe in the case of diabetes, the more they order imaging. It's something they can get reimbursed for. So in terms of productivity demands and expectations for billing for procedures, there's already an incentive to diagnose in that way. So then maybe the x-ray comes back, it shows like medial compartment collapse, like bone on bone. Then they might go off to an orthopedic surgeon to get injections. And then from there, they might re-injections it's just covering up the pain. It's not actually doing anything to treat the causes of it. So then they would go in and potentially say, well, you can either be on ibuprofen the rest of your life or get a joint replacement. And so at that point, they're like, okay, well, I don't want to be on drugs the rest of my life. I'm just going to go in and get the surgery. So that whole process downstream, you have to question a little bit, because was the medial compartment collapse in the knee the cause of the pain or the stiffness to begin with? What if the other knee has exactly the same medial compartment collapse but they have no pain on the other knee. So what if you take that same case, tell them you have some stiffness in your knee. When do you feel stiffness? Well, it's when I sit and when I do yoga. Okay, well, what joint range of motion do you need to sit and do yoga? Okay, you're lacking some knee flexion. Oh, it's quite a bit different on one side than the other. Let's get it to normal on both sides. Maybe get some more strength in that side compared to the other. And then lo and behold, their knee pain goes away. So you tell me, was that knee pain from the bone on bone? Are we just facing an issue of mass misdiagnosis in our system just because everyone wants to bill for procedures? We're not trained as clinicians outside of physical therapy, in my opinion, on how to diagnose based on root causes. And it's not always physical. It can be what we think and believe that feed our pain patterns. But to your point, physicians don't get a lot of time with patients, and it's not their fault. It's the system trying to get more and more billing out of more, each day. And I think the whole thing about compliance relates to this too. I hate that word. Who wants to do a laundry list of exercises? 1, 2 things, maybe at max. Who has time to do more than that? But the amazing thing is we're self-healing machines. This is the biggest secret the medical system doesn't want to recognize. If you leave it alone, most people get better. In research studies, if you compare one treatment to another, it's really hard to show an effect between groups because everybody gets better over time. It's called spontaneous recovery. So if we just keep people out of the system, and our platform does that, avoid a ton of claims. You don't need to.
I've had rotator cuff issues on my right shoulder twice. I'm sorry, on my left shoulder twice. And in both cases, I did get some cortisone shots the first time. The second time, I just dealt with it, and I said it's either going to get better or worse, in which case I will have to go do. In both cases, it just got better all on its own. So I can testify to the spontaneous recovery. So what I'm hearing from you is, but I think somebody might say, okay, wait, she's a doctor of physical therapy. She comes from that. So she's pitching physical therapy as the solution. And what I'm hearing is that's not even the case necessarily.
Yeah, I think it's a lot simpler because even being, a clinician in a physical therapy clinic, they're pressuring you to see patients for 6 visits, 12 visits. Why? They can bill for it. It's the same problem in the hospital system. So it's goes beyond physical therapy. People need high quality education upstream. This is not a surgical problem. You just flip the switch. There's no exercise needed in most cases. We need to get to them early, tell them they're going to be okay. Like their body's going to heal. And that's more in low risk cases. If there's a high risk case that comes, there's sometimes patterns we fall into or thought patterns that circle in our minds that put us on a high risk pathway. And then those need to be identified and treated through education. Again, it's not usually exercises, but for example, if you think, oh, well, my back really hurts, it's 8 out of 10 pain, I need to book an appointment today with my yoga instructor, the chiropractor, a pain specialist, and I'm going to see my next door neighbor who's an orthopedic surgeon, and I need to get in today. All of a sudden, you're seeing so many people getting so many opinions. That's a problem. We need to pull them back from all of those appointments and then have them only see us and eventually not see us. Like normally you don't see people for your joint. So, just how much time do I spend thinking about my left elbow? Well, that's the amount of time I should be thinking about my back after it recovers if it's fully better. I don't think about it at all. So the goal sometimes is to change people's thought patterns and, you know, just empower them, honestly, that their body's really good at doing something, which is healing.
All right, I want to talk in a minute. I want to come back, Heidi, and talk about how do we begin this screening process? How do we enter in further upstream? Because it's so hard to redirect care when you get a surgeon involved and that doctor-patient relationship kicks in, and the doctor, of course, is God. And if he says we need surgery, we need surgery. So I'm going to come back to you in just a moment on that. Mike, in terms of diabetes, where do you see, we talked about the problem a minute ago, what's missing from the equation that can get patients doing, but diabetic patients doing what they need to do to improve and maintain better health?
What's missing, I think, primarily is just, you know, like I said, there's so many barriers that exist to having them get the care, get the clinical advice that they need when they need it. You know, getting questions answered in a timely, you know, efficient way. Really, you know, at the core of our solution is just removing those barriers. You know, you shouldn't, we've sometimes been sitting with, we had one particular guy sitting with the CFO of a group, and he said, you mean my members have to go to see a physician and get a prescription and then and then get the prescription filled, and they're paying a copay both times just to test their blood sugar? That's crazy. Where, you know, and they just signed up as like a 5-minute sales meeting, our favorite kind. So I think really it's just about, you know, and when you look at it from the perspective of the I thought very well written paragraph that you put out advertising this episode, what we're really talking about is, you know, stepping back and looking at this as a, you know, really as a population health issue, rather than just looking at the person as kind of a claim generator, right? And so taking a step back and trying to get some data up front on the population, you know, we find that people are sometimes off by 2 and 3x of how many people with diabetes they actually have. And most plans, and you know that the CAA was passed and requires plans to actually understand their population, understand their needs, and then bring in solutions to address those needs. Well, we find, you know, at most people will tell us, well, we have X number of people with diabetes. Many people don't even know that. But as far as knowing the severity of it, type 1 versus type 2, you know, they don't know anything. And so I think for this audience, you know, the thing that's really missing is that kind of longitudinal understanding of risk, right? I think in both Heidi and our solutions, you know, look at populations that way, and what we're really trying to do is dramatically lower the risk from these two conditions for people, because like you pointed out at the very beginning, that's what really, you know, if you ignore these simple preventative things that you can do up front, relatively simple compared to the negative health outcomes they generate, you can dramatically reduce the risk, improve the quality of life of your members, and dramatically reduce your cost.
Well, I think we forget that a health plan isn't about fixing sick people. It should be about keeping them healthy, which aligns everyone's interest. The employer doesn't want to spend money on healthcare. That's money that they could spend on something else. The employees don't want to be sick, right? Now, accidents are another story altogether. That goes to the safety program at work or what have you. But around illness, especially preventable illness, I think we miss the mark entirely in healthcare. where it's so reactive, and it is, well, it derives from the fact that we structurally have a sick care system. That's where as Chris Rock famously said, the reason doctors don't cure anything, there's no money in the cure. The money's in the medicine, and the money's in the treatment, I will add. And so, both of you are actually bucking up against you're frustrating the inertia of the system, which is designed by the powers that be to drive revenue. And revenue is driven by sick people being treated for being sick, not sick people being treated to heal themselves. Heidi, what in the world? Where is the money in that? Or not developing all the comorbidities and having to lose a foot. I have two friends who've lost their foot or lower extremity because of diabetes. And it's a miserable disease. All right, Heidi, how do we enter in early on in the process and avoid those downstream costs, but also the downstream consequences, both of unnecessary radiation from diagnostic tests, but also unnecessary surgeries? Not just unnecessary in the sense they don't work, but unnecessary in the sense that the poor employee has to endure the trauma of a surgery.
Yeah, no, that's a great question. We talked about the problem, but what's the solution, basically, right? I just, before I answer that, wanted to highlight what you just said, Nelson. It's so powerful. Like, our system is built to make money right now in healthcare. That's a problem. It's got to be about the health of the patient, right? So, like, that's what motivates me every single day to do what I'm doing. It's like, we need to reshift healthcare about what's best for the patient. And it's hard. Like, I have VCs and whatever, like, everyone's focused on the revenue. And I keep pushing back, and I'm like, it's the patient that's important. The patient will always be most important. And education, like Mike was saying, for Diathrive, you can't really bill for that well as a primary care provider. As a physician, what do you bill for if you just talk to the patient? But the most powerful thing upstream, to answer your question, is education. So I think that's the leverage that DPCs, Diathrive working directly with the member base, Aware Health working directly with the member base, is to create an easy system that puts what's most effective upstream. And that's actually caring and talking to the patient. So at Aware Health, you get a same-day appointment, no hoops to jump through, no referrals needed. You have pain, get a provider in a near live time period. And then you get somebody that really has time to understand and care about your problem. You'll start to learn so much about the patient. Oh, well, I think I'm going to have back pain the rest of my life because my mom had back pain her whole life. And I'm afraid I'm going to turn into my mom. It's like, oh gosh, do you know if you see physical therapy in the first week, there's like 98% chance that this is going to recover in a few weeks. Oh, okay. And there's this immediate realization. What did I do? I didn't put my hands on the patient. They didn't do any exercises. I just told them, well, actually, the data shows that you're in a really good risk group, like very low risk, and this is going to resolve quickly. You don't need imaging. You don't need to see 5 providers. You don't need to sign up for a 12-session package of physical therapy. You just need to go back to life, because life is the best exercise. So, frictionless system, be there same day, care about the patient. It's not rocket science.
There is an emergency room physician Indian, he's an Indian extraction. He's born in America. You hear him talk, you would not know he's from India, but he is, and his cultural upbringing is Indian. And I mention that because he has a very interesting perspective on healthcare. His name is Anup Kumar, Dr. Anup Kumar. And Dr. Kumar says that Americans should, when they have a health issue, before they go to alternative care, should take advantage of traditional medicine. And only then, if that doesn't work, look to alternative medicine. And it might raise the eyebrows of some of us who are not hostile to alternative medicines, until you understand that what he means by traditional medicine is food, movement, rest, and socialization. Only when those don't keep you healthy do you repair to alternative treatments like drugs and surgery.
Yeah.
And so to your comment about go live life, well, that means go be around people, go eat, go get some rest, and move. And I loved what you said earlier. It's like, well, one knee isn't giving me the motion that I need for yoga. Well, let's get the motion there. And all of a sudden the pain goes away. So, okay, Mike, I'll ask the same question. How do we get people out of the status quo model of self-maintenance, which obviously is not working well for a lot of patients? Oh, I want to back up for some real quick. You were saying that employers don't know how many diabetics they have. How many of their employees don't know they're diabetic?
Yeah, that's a big problem too, for sure. And maybe to build this in with, with, I see the first question here from Robert Dill, says, what employee health assessment tool have you found to be most effective? And your answer partially addresses that, in that there are a lot of people that, because of the structure of the healthcare system, are out there with issues that they don't even know about. And Patrick Thornton then asked the question, you referenced that we need to change the mindsets of our members. How do we do that if we're working against what a doctor might be recommending? And what we found is that one of the things that we face, especially if we roll out to groups where benefits are, a meaningful part of the compensation package, especially school districts, other government entities, places where having diabetes, for example, might impact, their fear, the members' fear is that because we're contacting them, their employer knows they have diabetes. And so, and that relates to your question too, right? Because if I have that belief internally that my employer might fire me or might reduce my hours or not let me do certain things because I have MSK conditions or diabetes, I'm not going to answer that question. And so to Robert's initial point, I think what matters is less the tools that you use, and more about how you approach the individuals about their benefits, right? I mean, it's more about, do you have a relationship with the person? And frankly, that's, I think, part of the benefits of the Diathrive and that Aware bring to the table, which is that we're kind of an outsourced person. Whenever somebody says to, we have people get mad when they get our welcome kits, when we know they're testing their blood sugar, we know they have diabetes, and they say, am I going to get fired? What's my employer going to do with this data? And we as providers to their plan get to say, we're not passing back any personally identifiable information to your employer. We're just a solution that your employer has brought in because they know that your plan is brought in because they know that diabetes is a big problem or MSK is a big problem and we're not telling your employer. And that is a big part of the problem in terms of getting people to give you information, right? Because they've got to know that this is kind of like a safe environment, that the person that they're talking to isn't going back to their employer and saying, better get rid of Mike. He has diabetes, which believe it or not, is a very common perception, that we get. I would imagine the same is true at MSK. They might be afraid that, that if their employer finds out that they're gonna, they might file a workman's comp claim or something like that, right? And so a lot of it is about how these issues are approached more than about, which tool you use to do it, right? It's about just how you do it and the type of the way in which the person is addressed and the way in which benefits are offered. Because, like you say, you're not going to find out about things unless people trust the people that they're talking to. They're not going to be willing to give up information, like whether they have diabetes or any other health issue.
So Heidi, how do you recommend that we get employees accessing this approach as opposed to going to their primary care doctor, being sent to get an image and then being sent to a orthopedic surgeon?
That's an excellent question, and one that I have spent 4 years of our company trying to solve so far. And probably a question that everybody has listening to this is like, how do you get to them before that first image? Because once they get that first image, that visual is in their minds. They see a large, disc space that's collapsed, or medial compartment in their knee that's collapsed. They're going to start moving differently and thinking differently. So I don't know of any company that we've worked with where we just send a link and offer our service and the floodgates come to us. Like, if that doesn't happen. And so very early on in our company, I realized we got to go to them. And to do that, you need data. So we've built our whole system to get data from the TPA through push or pull. We develop watch lists, and we do proactive reach out based on those watch lists. We don't use a stick, we use a carrot. We give some kind of incentive, like a gift card. And, they're not going to come to us if we don't go to them. And the TPA is not going to do that. They're just going to report to you, oh yeah, there's a $200,000 claim, that messes up your plan for that self-insured group. Like, that's a lot. And somebody needs to be predicting that claim and getting ahead of it before it lands on that self-insured employer spend. So that's what we do.
So in addition to that, is there an educational component where you simply are letting employees know that if you have joint pain or they don't know what MSK is, of course, so probably joint pain, knee, hip, shoulder, call this number to get relief or something where there's an attempt to get them to respond? Have you tried that? Has that worked?
Yeah, we do all of it, and you have to. Our engagement, like typical MSK vendors, have about 5% engagement, and we're sitting at about 24, 25%, like 5 times that. So in order to avoid surgeries, you need to engage the population. If you have low engagement, you're not going to avoid many surgeries. So
No, it's all engagement.
Yeah.
I mean, you can have the best stack of cost containment and quality care solutions on the planet. And if the employees aren't accessing, something terrible happens. Nothing.
It's population health. You have to understand the data. Which groups are at risk, which groups need to hear which message to help them move the needle and engage, and what strategies are working. We have like 8-10 different strategies, and based on the customer, we can customize to what works for them and quickly turn on and off different strategies. So it's definitely an iterative process, but growing my company, I can't afford to not get good engagement. So if a group signs on with us, we will get good engagement. We might need to show up and knock on their office door, but yeah, we really provide an app plus a human experience that's there in their faces, where we develop that relationship with them and engage them.
All right. So you operate on a PEPM. Yes,
We
Heidi?
do it different ways. We can do a flat fee, but basically we put 100% of our fees at risk.
Well, that's
So
where I was going. I wanted to get to
we
that.
align on the methodology of how you know, show that, and we have our dashboard set up, and we share all of our data with the advisor, with the you know, in an aggregate way with employer, not on an identified way. But we align on that and then say, we only want to get paid when you save. So the incentives are aligned in that case.
Okay. That's, I mean, that is the very essence of next gen, is aligning incentives. That's the biggest problem we have in healthcare. The problem we have in healthcare is misaligned incentives. You
Yep.
fix those, everything else will fix themselves, because we're very creative and ingenious in responding to our incentives. The problem is the incentives are bad in so many areas. Mike, so let me ask you.
I want to
Go ahead, Heidi.
interrupt for one moment and just put a little caveat to that. Because yes, the advisor looks good when the plan saves, right? We look good when we save, because that's what we're trying to do for the advisor in the group. But I still want to say it comes back to what's best for the patient. So if surgery is necessary, it's going to make me look worse, it's going to make you look worse as an advisor, we still recommend surgery, because you have to keep what's best for the patient in mind. And sometimes what you know is best, they don't choose. But in our company, we want to empower the individual with all of their options. And we make a really good case. Like, why wait 2 months for surgery when you could start now and start feeling better? Who's going to say no to that? But in the end, it's their choice. And there might be some disagreement amongst everybody watching this on that. If you give the choice to the patient and they're driving up medical spend and it's not good for them and putting them on, you know, through more risk, is that the right thing to do? I think at Aware Health, it is, because we're all on our own journeys, and you have to have the freedom to choose. And ultimately, maybe we don't catch them with that one surgery. Maybe we're preventing a revision after that surgery. Maybe it's preventing the post-operative PT after that surgery. But it's always the patient's choice. And that's kind of what I stand by in terms of like patient-centered care.
And well, in everything we do right now in next gen, it's always mandatory. It's always voluntary. The employee chooses to do the right thing or not, and that's their choice. So Mike, how does Diathrive work with a plan, and what does that look like?
Yeah, certainly to Heidi, you know, we worked with Milliman to do a claims, you know, create a claims analysis module. So upfront for anybody, you can give us whatever data you have, and we'll show you the savings, and we put 100% of the fees at risk to guarantee that savings. And when we roll out, that really helps us on the rollout side, because then we already know who has diabetes, and we also know who's testing their blood sugar and not. And so our rollout goes first to the people that are already testing their blood sugar, and we lower the costs of them doing that by about 75% for plans. And then we work with the plan and the advisor, depending on their strategy, to go and try and get those people who aren't managing their diabetes to start managing it, because that's a big source. There's a huge difference in risk and in savings when you can get those people to start managing it. So it's really simple. And we do the claims analysis, by the way, for free. So you know, we do a lot of those every week. So you know, people don't even need to be working with us to have us do that.
And so Patrick also asked the question, how do we work with these partners? Diathrive is diathrive.com.
Yep, Michael
Yes.
at diathrive.com is my email.
And Michael at diathrive.com, not Michael, AEL. And Heidi, your website is awarehealth.io.
Yes. I is an igloo, O is an orange. So it's kind of a new .com.
So there you go. And it's Heidi at awarehealth.io.
Yeah.
For email.
HEIDI at a warehouse.
HEIDI.
Mhm.
So thank you both. I think we're really onto something here, which is refocusing on the front end and addressing the population health, not just the population sickness and illness. So thank you both for coming on, for making our December Healthcare Lounge extremely provocative, and wishing you both a fabulous holiday season. And for those of you, this is the last Healthcare Lounge for 2024, but we'll be back in January, and we'll be getting information out on the schedule for the first part of the year for Healthcare Lounge. In the meantime, I'm Nelson Griswold for Next Gen Benefits. Everyone, have a fantastic holiday season. Talk to you soon.